There's a lot one can say about health systems in a challenging world. One could be speaking about hours, and indeed, Minister Martins has already put on the table some of the key fundamental issues there. So I looked at the excellent program that, as I said, covered many of these issues, and I thought, what is my best value added? I thought, let's reflect on transformation. Let's reflect on implementation. Let's reflect on the political economy, on making these very important changes that we all agree about. First, the fourth horseman of the apocalypse, the health systems challenges. When I used this slide first many years ago, I never thought that actually pestilence and war and death, if not famine, would be an issue in this continent. Of course, I'm using it from a different, slightly ironic perspective, famine being the burden of chronic disease, war, the citizens' unreasonable expectations, pestilence, the spread of very costly technology, I'm provoking you, of course, and death. I'm provoking you less here, I think it's much more realistic, death by financial unsustainability. The challenges that we all think about that are in front of us would take, again, a whole conference to debate in detail. Let me just give you a couple of highlights, again, hoping with all humility to have some value added in the following discussions in these 2 exciting days in the forum. So a couple of highlights. The first reminder is that chronic conditions account for the largest burden of disease and healthcare costs. There's plenty of data. The data here you have is in the US, over 50% of healthcare spending is for dementia, cardiovascular diseases, strokes, and diabetes. And 86% in this case in the US is explained by multi-morbidity. In fact, there is this inverted pyramid that I'm sure you've seen, that 10% of the population accounts for 80% of the cost of the system. So when we talk about innovation, when we talk about digital, when we talk about health workforce, we need to have these numbers, we need to have these challenges of these chronic diseases. And yet, we do have the evidence. Many of these, even chronic diseases, many of these diseases that account for 80% of the population are both treatable and preventable. These 2 slides, these 2 figures here, which I don't have time to go in detail, all this is material that the Observatoire has been publishing. This comes from a country profile that we do for the European Commission, for the European Union. It shows the preventable cause of mortality and treatable cause of mortality, standardized rates. It shows the U27, actually Portugal doing better than the U27, but there's still some space to improve. Another reflection on this broad apocalypse horseman. We had the COVID pandemic, but there's another pandemic that we were not taking seriously. This is the antimicrobial resistance. It's already causing 35,000 deaths per year in the EU, and there are some scenarios that talk about 10 million deaths globally each year, reduction of 3.5% of the GDP. And this is very much one of these areas that gets me very stressed and unhappy. I was presenting in the Belgian presidency of the EU, which was on AMR. This brief here is a brief that we did for the presidency of the Belgian presidency. Do you know how long we had legislation, national plans for dealing with antimicrobial resistance? WHO and the EU has plans from the beginning of the century, and we're still struggling with washing hands in hospitals. You know that Semmelweis, I'm honoris causa from Semmelweis University, 150 years ago, died in ignominy because asked doctors to wash hands because he realized that doctors that were in the autopsy room and went to deliver babies caused lots of mortality. He died unaccepted by the medical profession. 150 years later, we talk about health professionals washing hands as one of the challenges. And that's a bit the talk today. This transformation, this change. Why member states are not coming together with accountability to ensure that those countries that are using too many antibiotics, there are huge differences in Europe, reduce the use of inappropriate antibiotics. That's another challenge that reminds us as well that the evidence of the challenge is there and the evidence on the interventions is there, and yet somehow we don't bring it together. One final challenge, a challenge which is here in the room, which is the elephant in the room, which is while during COVID we got lots of resources, there was an increase in expenditure. After COVID, this is the average for OECD countries. In some countries, in percentage terms, the growth has been negative. So Cinderella Health was in the ball with the Prime Minister, with the Minister of Finance. Health was important because of COVID. Is Cinderella, is health back in the kitchen? Are we going to bring Cinderella back into the palace of the Minister of Finance and the Prime Minister to get the actual resources that health and health systems needs? This is yet another challenge which will be permeating today my presentation. So my reflections are, in the next 23 minutes, quite predictable. Andrea Lima was mentioning them, Minister Martins was mentioning them. Acting on health determinants, indeed, health for all. We have to do that, yet we're not doing that enough. Demonstrating that health has co-benefits in other sectors as well. How we make that case to bring Cinderella back from the kitchen to the central stage that we had during COVID, to invest on health. Strengthening health governance, international health governance. I'll give you some reflections on that. I just arrived from the World Health Assembly in Geneva. Innovation is there and has enormous promise. Are we harnessing that promise? Recruit, yes, but retain and reskill the workforce, and how we drive all this transformation. A reminder, behavioral risk factors account in Portugal for 1/3 of annual deaths. And mind you, in average terms, you are doing better than the average of the EU, both in terms of percentage of deaths from tobacco, dietary risks, alcohol, or environment. But still, these are obviously preventable behaviors. Not easy. This is where I'm talking about transformation. But we know they're there. We know they're a major cause of disease. Another theme in the overall health for all is acting on those determinants that will change the behavior, will act on the behavior of our populations. Now, and I was glad to see also that the forum will deal with One Health, will deal with this concept now of One Health being not only human health, but being related with animal health and environmental health, which is central to this challenge I was mentioning a minute ago about antimicrobial resistance. This challenge about the fact that if we want to deal with antimicrobial resistance, we need to look not only at human health, the use of antibiotics, the quality in hospitals, but also at the use of antibiotics and husbandry practices for animals, as well as environmental health. So this concept is taking real root. The concept that One Health is not only environment and animal and human, but also is housing conditions, is war, is poverty, is taking root. But are we seeing real work in all these factors? Are we health there on the table, making a case to act on those determinants? How do we bring, again, the politics of health to bear on environment, to bear on poverty, to bear in all these other factors? Take this, please, if you pay attention today to one thing, read this sentence from the Lancet. Just for industries account for at least 1/3 of global preventable deaths. Unhealthy processed foods and drinks, fossil fuels, alcohol and tobacco. They cause 19 million deaths annually. This is the food processed industries. Some of those have a larger GDP than small countries in the world. This is the determinants of health. This is where we need to do international governance. This is where we need the political power and leverage to work on these industries. So first part, acting on determinants. I gave a very quick view of an area is rather complex and long. Still, I hope brought some thinking ideas there. The second is not only what environment, economic poverty can do for health, but what health can do for you. It's not only the environmental co-benefits of health. If the environment improves, we'll be healthier. If people are richer, we'll be healthier. But what health can do for the environment? Now there's a big hype about the greening of hospitals. Because hospitals, health systems, pharmaceuticals account for 8% of the carbon footprint. So what can we do to demonstrate to the environment that investing on health is good for the environment? What can we do to demonstrate that healthier kids are easy to educate? What can we do to demonstrate, these are the SDGs, that better health for women really adds to gender balance? So a lot of the debate has to be from the perspective of health. We demonstrate the health co-benefits, Andrea Lima was saying that at the beginning, also to other sectors. That's perhaps another element that can help us in my third reflection today. How do we make and communicate? Communicate and communicate. Every time I've been asked what are the 3 lessons of the COVID pandemic, were communication, communication, communication. Communication is central in health. We need to make our case to get the kind of behavior we want in our populations, to attract the kinds of resources. So again, COVID has given us this window of opportunity. I keep talking about Cinderella, I'm sorry. We're back in the kitchen, but we still have that window of opportunity. Health, our prime ministers, our key stakeholders, the IMF, the G20, have realized that health is good for security, is good for sustainability, is good for well-being. We've been doing a lot of work, this is just 2 of the publications, about how to make a case. And we realized it's not only the numbers, and I could spend the next half an hour, 3 hours telling you about the value for money, how you invest in prevention, you get 10 times return. How you invest in prevention, you get human capital that is more productive for the economy. There's a lot of evidence on that. But we don't quite get there. What we learn is that, and you have a very good session as well, when we go to the Ministry of Finance, we not only say these broad numbers to get more money, or the Prime Minister, we need to show that we are very strict and rigorous within the health system. That we have value-based care, that we have reduced waste, that the health system is not a black hole where we should put the money. We are not in a spending sector, we're an investing sector. But to show we're an investing sector, we need to demonstrate that indeed we are a value for money. Are we investing in the kinds of interventions that have a return in society? Sorry if some of that probably is not that original, is pretty basic. Somehow, these are reflections based on seeing so many reforms and perhaps failing to realize the implementation, the transformation elements, which brings me to strengthen international health governance. Health is a public good. And what is a public good? You all know that. Even the Chicago neoliberal economists would agree that there are things that have to be done by the public sector. I'm not saying that the public sector needs to do everything on health. Do not get me wrong. I'm saying that health is a public good that needs public intervention and international governance. I'm very sad. I just arrived from the World Health Assembly, as I told you, and the pandemic treaty is not yet approved. Member states have agreed to another year of negotiations. And why? Is anybody here disagreeing about the need of international pandemic treaty? Well, geopolitics, north-south, power balances. The European Health Union, how much space there is for subsidiarity on antimicrobial resistance when cows, people, and doctors cross borders. Doesn't matter if Portugal does very well, if the Spanish don't. I'm not saying that's at all an illustration of reality. If borders are open, and remember, many determinants of health are now global. I was telling you about the commercial determinants of health. Migration issues. Many of these issues that affect crisis were tied together. So a key element now is how do we work together with new global instruments. And although we're in the right direction thanks to COVID, there's much more that we need to work in this area. This is some work we're doing for DG Santé. We're running a series of debates asking populations and stakeholders as to what's the value added of the European Health Union. And it's interesting, when you don't ask governments, when you ask the doctors, the nurses, the stakeholders, the NGO, the civil society, they see many areas where an European health union can play a much bigger role because many of the determinants and issues are common challenges to all of us. Health determinants, climate change, systems resilience, healthcare workers' labor market. Again, the Observatory had the privilege to work with the Belgian presidency to look at the health workforce. And now the Belgian presidency will put together a EU strategy for health workforce, systems transformation, digital solutions. I'm very glad, happy, you all know probably that the European health data space legislation has been passed. That will be a major opportunity to learn from each other, to draw on what the minister was saying, that huge potential on digital health and data. Fifth, it's a shopping list, a long shopping list, sorry about that. Harnessing the promise of innovation. Yesterday I was in Rome. Actually, Portugal was very visible there, presenting some of its work. Portugal has, congratulations, a long history on digital health, actually. In the south, in good part of Europe, you have the Nordics, Finland, Denmark, Estonia doing very well. But then Portugal, it's following behind, not that far, as one of the leading countries in comparative terms. Probably you are unhappy, you would like to see much more. But in terms of, and I remember, Alberto, during your mandate, you pushed that area very much as well. In this area of innovation, in the area of digital health, in the area of telemedicine. So we have all these opportunities we'll be discussing these days. Some people say, and the debate out there is aging is no longer is a disease. The aging is behind the many of the diseases, and what we need to do is deal with the actual causes of aging. That's just to highlight, to provoke a little bit. Let me just make a couple of comments. As I said, I was in this HIMSS conference, European Conference on Information Systems and Digital Health, and we were discussing some of these issues the last 2 days in Rome. First, the regulatory conundrum, particularly in AI. What I see is innovation technologies, particularly in AI, are growing exponentially. We stakeholders kind of realize, but don't realize what's going on. but the evaluation and regulatory efforts are very, very slow. So you see this. I am not saying regulation to reduce. I'm not saying regulation to restrict. I'm saying regulation to harness. I'm saying regulation to steer. Actually, when you talk to the industry of AI, it's looking for leadership. They are moved by commercial determinants. The AI industry, I'm running, actually, great conference, European Public Health Conference, will take place in Lisbon, as you know, Minister, and the Observatory with WHO will run the plenary on AI and public health. And guess what? AI is not that interested on public health, on assessing risks, on communicating risks. It's not what AI gets the money out of it. So that part on evaluating and regulating and steering AI and digital we are doing, not AI, is very important. But of course, it's complex. This is some work we did for the Finnish presidency, and we call it regulating the unknown, talking about the genomics. This innovation is going very fast. We need to regulate it, but we don't know what's going on. So if we're talking about the challenge to harness innovation, it's very much about how do we regulate, how do we steer, how we step up these efforts. The second one, which is as important, we all talked about that many times, and I apologize to repeat it, is digital is not only, and it's been said, technology. It's not only new gadgets. It's how do you embed, how do you integrate, how do you implement. Why telemedicine, which is a telephone, had been for so long around, I'm facetious saying it's a telephone, but basically it's a telephone. Why telemedicine had been for so long around, and only during COVID took such a peak? Countries pass legislation in a matter of 2 weeks. Countries change incentive systems in a matter of 2 weeks. We work with several countries in doing that because of the pressure. So the telemedicine is there, was not enabled. The incentives, the regulatory frameworks, the professional cultures. There are some countries in Europe where they have the resources, but the medical profession doesn't trust digital health because of the control element of it. The training elements, the skills and training. So please, when we talk about innovation and digital, let's think about those incentives. Why a dermatologist would have an incentive to look at the images from general practice of some dermatological lesions? Actually, Portugal, I always use Portugal as an example, that introduced incentives. And now 80% of dermatological cases that go to a hospital have been seen in primary health care because, having seen through teledermatology, through a picture, because the incentives were introduced in the hospitals to actually not admit having to see at least 80% of these patients through dermatology before they're seen by the specialist there. I'm talking about the health workforce. Are we realizing, this is just a study showing that much of that health workforce, and see, for instance, I'm being now simultaneously translated, no need for interpreters anymore. Not sure it's doing it very well, but it's doing it. Do you realize that in health care, many of that workforce will not be needed longer required through AI? Are we looking at all these elements when we look at innovation? But what is the future of AI? We see robots now taking care of patients, particularly in Japan, but more and more in the Northern Europe. Well, my view there is that the most scarce and expensive innovation in future may end up being human contact because of the aging of the populations. So we have to be cautious, and indeed, to go to my sixth reflection, I only got 7, and I still got 6 minutes to go. I got 7 reflections, so let me now reflect, again, Mr. Martins has talked about that, to the health workforce. this is the major challenge, which is a challenge that will require lots of transformations, lots of change of paradigm if we are going to manage. We have problems of recruiting. The health profession at all levels is not very attractive to the young people, young population. There were some studies saying that at the rate of demographics, 1 every 3 new babies will have to work on health or social care. So tell me how we're going to do that. But it's not just recruitment. It's retaining. We're losing nurses and doctors all the time to other sectors, particularly nursing and other allied professionals. And reskilling. And here I will relate it with the whole area of innovation I was talking about. So we do have a shortage of health workforce, particularly in primary health care. Our neighbors, I was talking to your counterpart, Minister Garcia in Spain, was telling me that in primary health care, resident training posts are left empty on primary health care when the needs are enormous. It's an aging workforce. Here you have the doctors over 55 in various countries. Portugal, with this green-red arrow, is around the average for the member states of the WHO European region, around 33%. In some countries, it's really concerning to see this very large percentage of aging doctors with no new supplies in the system. Maldistribution, burnout and poor mental health, poor recruitment and retention. I like this. This is as well work that is in that country health profile that we do for the European Union countries with the OECD and the Observatory. That tells you 2 stories. One, the shortages in some countries, and the skill mix. This has a vertical and horizontal axis, number of nurses and number of doctors. You see the lower left quadrant, the lower, maybe dyslexic, the lower left quadrant, with countries both with low doctors and low nurses. Portugal seems to be about average in the numbers of nurses and above average in the numbers of doctors. What does that mean? I don't know. It means that there are huge differences. It means that if we don't know how many doctors and nurses we need, do we know about the other mix of professions we need? This is a way to remind you about the importance of the skill mix. The importance to find the right skill mix in health system, and another one, of course, a warning about these shortages that are coming and we need to work on. You don't have time or energy to look at all the materials in this slide. It's too busy, I know that. But what I wanted to do is highlight this idea of that can deal with some of the problems together with digital and innovation, the problems of the shortage of human resources, which is the shifting tasks, the new roles and teamwork. Health is not about doctors, it's not even about nurses, it's about all sorts of other professionals. Here, I give some examples about extending roles for nurses, reallocation of roles as well to nursing and other professionals. For instance, pharmacists in the UK take care of chronic diseases on the chronic prescription and controlling them for diabetes and others. Supplementary roles, patient navigators, even involvement of the patients in actually training other patients, teamwork and collaboration in which the doctor is not in charge, other professions are in charge for mental health and others. You know that, I know there are many schemes, we've been studying that in Portugal, that are taking place in Portugal. But my argument is we need to step that much more if we are going to address this huge challenge with the shortages. And the point here that the Observatory, again, is the same point, colleagues, is the implementation. I always use the same example, perhaps you heard me saying that. I used to be a GP hundreds of years ago, and the nursing professionals with whom I was working were prescribing for chronic diseases in my health center, in informal way. Still, Spain has not passed legislation, formal legislation, on nursing being able to prescribe for chronic care, when we know that they are far more effective than doctors in some of these kinds of tasks. The point is, it is the regulation stupid. It is the culture stupid. I'm not calling you stupid, of course. It is the regulation, it's the culture. It's doctors sometimes blocking nurses to do that. Sometimes in some countries it's nursing profession blocking other professionals. It's the enabling legislation that allows them to take these new skills. I've been told that I run out of time, so let me give just one final comment about driving transformation. Health systems are complex. This is the main message today. These are 3 country health systems. Health systems are complex within very complex systems. Even Donald Trump realized that nobody knew healthcare could be so complicated. Yes, Mr. President, healthcare is very complicated. And we still, even I that have been in this field for many years, I think of healthcare as this beautiful decision-making, assessment, formulation, options, implementation, evaluation. The reality is this one. The reality of decision-making is this one. What I want here today is let's acknowledge that that's the reality. Let's work with that. Let's find ways in which we learn about that. So a lot of the work of the observatory now is in transforming systems. So I see here, you can see here, the circle, the resources, the finance, the planning. But in the middle is the leadership role and the political will. It is the political economy, stupid. Understanding the political economy of change. Understanding the role of the different stakeholders, how they will defend their interests. How do you engage them? How do you do an analysis and engage them in change? How do you influence the stakeholders? How you recruit those who are positive to the reforms? How you increase or decrease power? This sounds a bit Machiavellic of some of those. How you steer public perception? A two-way communication, finding windows of opportunity during crisis to make change. So my argument today is that the evidence is there, the mechanisms is there, and what we need to do is understand the transformation implementation elements. And there is science, there is management, there are many, many ways to do that. Ultimately, a much younger Jean-Claude Juncker was saying, we all know what to do, but we don't know how to get re-elected once we have done it. And we need to remember that lesson when we talk about reforms and changes. These are my random reflections, which is very much from the what to the how. Nothing is very new, nothing is very original, but I hope adds a bit on the debate the next few days. Thank you for listening to me.